today, it was a little bit tricky getting this together because I was planning to provide pearls from the week-long course I took this summer. I was one of the, I think it was OBSSR, NIH sponsored a course on dissemination and implementation research, a training actually, a week-long training in North Carolina. It was the first one, and hopefully they'll do it again. One of the things they asked of us is that we go on the road with some of the slides we got from the course and share this information with you. There's a big push in the OBSSR group and NCI to really grow this field. And so I am going to give you some pearls from what I learned there, but I thought the easiest way to do this actually would be to combine that with some of the things that I'm doing to show you examples of what an implementation and dissemination project might look like. So I have one grant that is probably going to get funded, so I thought it would be worth showing you the aims and the theoretical framework we're using and how we're sort of posing that research question. And then I just finished a grant that, although it started as an effectiveness study, it actually became an implementation study. So with that, I'll begin. So this slide I got from the Dissemination Implementation Conference last year, and I thought it was actually a perfect way to start this talk. Where am I? You're 30 meters above the ground in a balloon. You must be a researcher. Yes, how did you know? Because what you told me is absolutely correct but completely useless. You must be a policymaker. How did you know? Because you don't know where you don't know where you're going, and now you're blaming me. So the point of this slide, you didn't get it, is that this whole talk and this area of dissemination implementation research is all about making the science more relevant. And really more relevant to policymakers, actually, because what we want policymakers to be doing, obviously, is to be doing evidence-based policymaking. And they can't do that without the evidence that we're producing for them. So on that note, let's define the terms. And these are straight out of the program announcement, and I'll give you that PA number later on the talk. The implementation science is the scientific study of methods to promote the integration of research findings into healthcare policy and practice. And dissemination, frankly, is almost the same exact thing. I'm going to focus mostly on implementation research because that's what the course really focused on, and I don't know that folks are that comfortable yet, I guess, thinking about how we would kind of, the idea of scaling up. Not a lot of work has been done in that area yet, but the idea is to go beyond the implementation stage and start to think of research strategies that you could disseminate your findings on a much broader level. And what are we implementing? The evidence-based practices. The objects of dissemination and implementation are interventions with proven efficacy and effectiveness. And I'm just showing you this because I think it's important to sort of pictorially see where this research fits. And this was a great article by Westphal in 2007, and he was the first to sort of propose the idea that you can't just go from T1 to T2, that there's a step in between that we're missing, and that is that there is a whole research area of taking best practices into implementing them into clinical settings. So that's and the place where all that happens really is in practice-based research settings or practice-based research networks. Now at the course, this was a slide presented by Russ Glasgow, who is the father of re-aims. Many of you know that model. And not to confuse everybody, but basically the T3 is there. But he was proposing, as was Corey in this article, that in fact there's a whole other translational step that has to take these evidence-based practices into the community and to actually impacting at the population level. So we've gone from sort of 2 translational numbers to now maybe 3, 4, 5. And the point of this is not to make us all crazy. But I really liked this article by Steve Wolf in JAMA in 2008, where he was talking about trying to make a real distinction between these types of research. And I think he was really reacting to the idea that there were all these funded clinical translational research institutes that were really focusing mostly on T1. And And when he says that they're like in name only, he's saying that the word translational may imply that these two movements from, along the range of research are both similar, but in fact they're very different. And so, just looking at the struggles in T1 are with biological and technical mysteries, trial recruitment, regulatory concerns, whereas the struggles in T2 through 4 are more with organizational inertia, human behavior, infrastructure and resource constraints. And the things that you need to know to actually do this work well go really cross multiple disciplines, behavioral scientists, economists, and the idea is that we're looking and evaluating interventions in real-world settings. So I thought this was a really helpful article to kind of really think about what the distinction is between these two. Please jump in with questions if you have them. So what are the key elements of implementation? So what's being implemented? How are we implementing it? And how do we measure success? And for that, answers to those questions, I'm turning to Enola Proctor's model, which is, again, a really good article to read. She came to the course and she spoke. And she came up with this because I think there's been a lot of confusion about what are the outcomes when you're doing this kind of research. So the what is the evidence-based practices or what you're trying to improve. The how is what are the strategies you're going to do that. And then, again, this is not a theoretical framework. This is just a way of sort of knowing what questions to ask and then how to answer them. So the questions on the left side and the outcomes that you would want to look at are on the right side. And so when you're thinking about implementation and you're talking in your grant about outcomes, you're really talking about fidelity, penetration, which I like to think of as reach, the acceptability from the patient and the provider's perspective. She talks about sustainability, uptake, and cost. Other people talk about dose delivery, dose received. So these are just some of the implementation outcomes. There are the IOM standards of care outcomes you can look at, and of course, patient outcomes. And I'm going to talk about my experience with actually getting reviewed on one of my grants and how this issue of some program officers are saying, well, your outcomes are really the first box there, implementation outcomes. You don't have to worry about patient outcomes. And then you get reviews back saying, where's the patient level outcome? So it's a tricky process, actually, because there's still the implementation. PA has a standing study section now after 4 years of being in place. And what they're trying to do is create a study section that really understands this world, and so that they can respond appropriately to the proposals and not be looking for sort of outcomes that really in this work are irrelevant. So what do we know? I mean, we do have some knowledge about implementation strategies that may or may not work. Practice facilitation has become a really interesting one. I think AHRQ is coming out with a whole guideline on how you do practice facilitation. I think in some ways that's taking over as the implementation strategy, although there's not a huge amount of research on this. When I talk about this HRQ grant we just finished, I'll talk about how we ended up realizing, even though practice facilitation was not one of the interventions we proposed, it ended up being the most important thing we did. But we didn't call it a component of the intervention. And in fact, so much of what you do when you do implementation is practice facilitation, training, technical assistance. And so it's something that needs to be out in front, because the implementation doesn't happen really without some practice facilitation. Audit and feedback, there's probably more data, frankly, on the value of audit and feedback and clinical reminders than anything else out there. Organizational level stuff, revision of professional roles, team building, care coordination. But there isn't a lot of good data on these things. And then Gleason has a model called ARC, availability, responsiveness, and continuity. And I don't have time to really get into it, but I have his articles if anybody's interested in his approach. He's done some work in implementing best practices on mental health, related to mental health treatment. Common dissemination strategies, social marketing, collaboratives, coalition building, media advocacy, agenda setting. It's not where I've been doing my work, so I don't have as much experience in this. So when we think about implementation research, again, the bar is going up in terms of getting this work funded, and there's an expectation, certainly at NIH, that you're going to have some kind of framework. And REAIM has been thrown around a lot, and of course Ross Glasgow was heading up this whole course we took, so he was very cute about presenting his model and saying, it's okay, you don't have to all say this is the greatest model ever created, but, and there are others. And in fact, Larry Green was there with pre-seed, proceed, and they were duking it out. But this is really, from my perspective, this is an evaluation framework. It's not, REAIM is helpful, but there are limitations on it. I just wrote a grant where I actually used REAIM, but then it blew up the implementation part to actually, and used a totally different theoretical framework for implementation. So in his model, implementation is really about measuring implementation fidelity. And again, fidelity is one of those really key measures in this work, because it's all really the effectiveness. It's all about whether the interventions, implementation strategies, were implemented in the way they should have been. There's Paris. If you go look at the query website in the VA, you'll see a whole bunch of these different implementation frameworks. Everybody's probably familiar with Rogers. Laura Damschroeder is at the VA. She wrote a beautiful paper that's worth reading and proposed a consolidated framework for implementation and research, where she reviewed all of the different models, and so came together with a summary of what are the key variables that you have to look at when you're trying to understand the important influences on successful implementation. Leif Solberg, in Annals of Family Medicine 2007, published a model that he's now funded actually to look at. And Brian Weiner, who, I'm sorry I don't have his references, but I do in my office, is also, he comes from the organizational change world. He has a PhD in that field and is, I think, a really wonderful addition to this community of researchers because he comes from a completely different discipline that is very important. And also I'm going to show you his model. The chronic care model, which everybody, again, I hope is familiar with, it's a model that's pretty old by now, and it poses 6 components that are proposed to be critical components to improving quality of care. I'm never going to remember all of it. Healthcare, service delivery change, clinical decision support, information systems, on and on and on. And a lot of times, in fact, I had done this, written that in as the framework on one of my grants earlier, several years ago. But now that the more I've gotten into this field, it's not a framework. It's really actually the thing we're supposed to be implementing. And if you think about it, it proposes these care processes, things that offices need to have in place. It's very, sort of at the organizational level, what needs to be in place to facilitate quality care. And so that's the way Solberg actually frames it, which I think is really interesting, is thinking about those processes, because the chronic care model never actually told you how to get those things implemented. It just said these things should be there. So a lot of the work that Solberg's doing is actually thinking about how do you implement the chronic care model itself and those processes. And that's been a lot of the work he's doing. Just to pause, because we can all lose our minds reading this literature and the model, so I really like this quote. Because it's really overwhelming, because this field is still really in its infancy, that everybody and their cousin has a new model, and none of them are really set in stone. So when you do behavioral research, it's kind of nice. You can go to the old favorites, theory of planned behavior and health behavior model, and there's just a lot of evidence behind those models, but this is a really evolving field.
Is this the originator of the box plot?
Oh, I don't know. So let's look at someone who's got funding to do an implementation study. This is an R21 that Brian has, looking at implementation of colorectal cancer screening. And this is his model, and it keeps evolving. The intervention is outreach and support, training and technical assistance, and they also have a toolkit. And the hypothesis is, and again, what's nice about what Brian's doing is he's really trying to create a causal model, which really doesn't exist in this field, and saying that outreach and support and training and technical assistance will lead to the implementation of certain policies and practices that we know, again, CCM, kind of chronic care model components, reminders, audit and feedback, all of that will actually change the implementation climate to provide the sites with the means, the motive, and the opportunity to do what they need to do around colon cancer screening, which will lead to implementation effectiveness and innovation effectiveness. And implementation effectiveness is that sort of intermediate outcome of looking at were the sites adherent to what they were supposed to be doing? Is there fidelity? Was there reach? Was it implemented in the way it was supposed to be implemented? He throws in innovation values fit there because that is been shown in a number of studies to be very important. How he's measuring it, I don't know yet. I think that's a question out there in this field. He's sort of all these terms. He's actually developing a tool to measure implementation climate. There are tools out there as well. So this is just one example of a model that's being evaluated, and he's assessing the extent of implementation of office system changes that would promote colorectal cancer screening using Toolkit and this outreach support method. Another model is Solberg's model, which was published, actually not in this, earlier than this, where he looked at all the literature and his own experience and decided and came up with this idea that you need organizational priority. The organization has to have the capacity to change. You have to have the CCM care processes in place, and that will lead to quality improvement. And all along you have facilitators and barriers. So he actually has a study funded by NIMH and HRQ where he's testing this model, and he actually fell into a really nice natural experiment in his state where the state agreed to change the reimbursement for mental health services. And so he actually is doing and he actually proposed a different way of looking at this. He's doing a multiple baseline staggered implementation design. Couldn't randomize the sites because everybody was going to ultimately take this on. And so to do the research, that's what they're doing. So he's hypothesizing that the reimbursement is going to increase the organization's priority, that practice facilitation will actually change processes, the change process capability will enhance the capacity of the organization to make change. They'll be able to put the practice systems in place, which will lead to best care processes for mental health, improvement in depression, and they're also looking at healthcare and healthcare costs. Any questions?
Where is that taking place?
In Minnesota. So some questions that come up, I was at a talk at Sloan where Russ Glasgow spoke, and a lot of basic science researchers were there, and they kept asking, what's the bottom line? What's an IR question? Like, how do you even pose a research question like this? So I just threw up a couple. I'm going to show you mine. These are just some examples. What's the effectiveness of an organizational implementation strategy on climate and culture and adoption of evidence-based treatments? Comparing different strategies for disseminating a guideline for diet and exercise to teachers in school. Do organizations that employ learning disciplines or QI approaches implement change faster or better? I mean, just on and on. And if you look at the PAs, they actually have a whole list of suggested topics. But it's not kind of always your typical hypothesis-driven, aim necessarily. So before I get into this example of my work, one of the best talks I heard was from Hendrix Brown, who has a center. He's a biostatistician who works down in Miami. He was given some money from NIH to start a center actually to look at different methods for studying implementation. And I have a couple of handouts there. One article that really does a nice job of reviewing alternative study designs, and then the handout that Hendrix gave us all explaining. It's like a cheat sheet on every design you can imagine other than an RCT. And it's been really helpful reading through this because as I struggle with my next application, it's just really tricky to be randomizing huge numbers of clinics. These sites are actively involved in quality improvement right now, and they don't want to be a control site forever, and it's inconceivable that they really would remain that,
Donna, can you say anything about randomized encouragement trials?
Yeah, I'd have to refer you to that. It's actually kind of, I love the idea of it, where people are randomized, but they get to choose what they want to do. And actually, if you could pass me one of the, I think it explains it better than I could. I'm pretty sure it's in that. Yeah. So trial participants are expected to adhere to their treatment assignments. They may be given strong incentives. Alternative participants may be randomly assigned to an opportunity or an encouragement to receive a specific treatment, but allowed to choose whether to receive the treatment. This variation is useful for the intervention for which it is impractical or unethical to require adherence, or in which necessary incentives would be unrealistic. So I haven't seen one of these. I don't think I've even read an article that actually used. Have you used one of these?
I don't know. I mean, it makes you wonder. I mean, some might argue that a poorly executed randomized controlled trial is a randomized encouragement trial, right? In the sense that people cross over. It's just interesting.
It feels to me really hard to get your head around how you would analyze that, and if they're not doing it, they weren't really randomized to that arm, and but yeah, it's an interesting question. I threw it up there because it's a conversation I'd love to have with a biostatistician thinking about this, because wouldn't it be interesting to let sites choose the kinds of, I've been reading about a study that's being done by Grimshaw and Eccles in the UK on tailoring implementation interventions. And it's obvious to anybody who does this work that each site is different, and they need tailored intervention strategies. And in some ways, this is like if you had a Chinese menu of things they could do, and they could choose what they wanted, you might have, my hypothesis is you'd have better outcomes than trying to pigeonhole sites into doing stuff that just doesn't work for them. The other thing to think about it is another paper I read recently, which talked about function versus form. This idea of that everybody has to do certain things. Like you have to do provider feedback, but you can do it any way you want. So that's sort of a way of tailoring and saying, this is what we think will work. Clinical decision support, you need a registry, you have to have audit and feedback. But in your site, that could happen in different ways. Using a mixed methods approach, which is very common in this work, to examine potential theory-driven mechanisms at the organization and provider level, hypothesize to explain the effect, and then identify baseline organizational factors that influence the implementation in these practices. So this was the study design. We're recruiting 18 dental sites. We do baseline assessments to assess at baseline provider adherence to tobacco use treatment guidelines. And it's a very simple, validated tool. Patient exit reviews are clearly the best way and the most accurate way to get this information. We also are planning to do baseline interviews of the providers and the directors, and I'll show you the outcomes related to that. We randomize them to current best practices, CBP plus provider feedback, and then all of that plus pay for performance. And then we do follow-up again cross-sectionally. This one doesn't end. When we first submitted this, interestingly, we went from not being scored to having a really good score, so there's hope. Not good score. But it was funny because the deal breaker seemed to be in this one reviewer that we didn't have a patient level outcome, that we were looking at provider level outcomes. Now, if you look at our theoretical framework, that made total sense. And in fact, the reviewer acknowledged that oh yes, I understand that the theory and everything follows that you would have a provider outcome. Also in this field, again, when you get to the implementation level, the evidence is already there that if the provider does this, patients will quit. So it's a waste of money, frankly, to actually go to that level at this point with this kind of stuff. There was a compromise to this. And we what he said was, or she, that they wanted some sense that the patient took up, like, the provider's advice. That there was something that happened. It wasn't like they wanted a 12-month cessation outcome, which frankly would be impossible. We didn't have the money. So what we did was when we resubmitted, we're following patients up at 3 months and asking about use of quit attempts, use of NRT, whether they called the quit line, things that the doc was supposed to tell them to do. And also we'll ask about abstinence. In the tobacco world, 3 months abstinence rates don't really mean a whole lot. But I think for this reason, I did buy the idea that it would be nice to know that there was something that patients did after they left the office that showed that there was some influence on their behavior. And they definitely went for that and really liked that compromise.
Isn't that part of fidelity though too?
Yeah.
It's kind of, as you scale up,
It
does
is.
it still have the outcome?
Yes.
I guess I'm not arguing that that's not important. I'm saying if you think about a study as always kind of taking everything all the way down the line, or you don't really build, it doesn't sound like a knowledge building kind of approach to research. It sounds like
But,
kind of like
But
I
no,
don't
but-
believe that anything generalizes.
I certainly think that would be a fair criticism at the argument where this should be a mortality study. You know, for example, if somebody were making the argument that you should be looking at heart attacks, strokes, and heart vascular disease outcomes. I mean, to me that would seem extreme for that very reason. But I just wonder if, to me that the argument that you need to go a little closer in terms of the causal stream to patient outcomes seems reasonable, but I understand that not everybody would agree with that.
So, thank you. This is a good conversation, actually. I appreciate that. And I just wanted to explain, what we did was we played with, Leif Solberg is a consultant on this grant, and he was very angry when he read the grant because he didn't like that I threw in the physician level factors there. It was interesting. He said to me, "You're going to get completely dinged. This should be totally at the organizational level," which I completely disagree with, because we're talking about provider behavior change. And that argument was strengthened by the beautiful work that Grimshaw and Eccles is doing. They are publishing like crazy on applying the theory of planned behavior to this work, and really making a very strong case that you have to measure provider behavior. I mean, provider attitudes or whatever the influences of provider behavior. So we combine, and again, most of this work is going to require combinations of theories. It'd be nice to think we can come up with some uniform theory. But I have to say that Brian Wieners also doesn't have the provider in there in his theoretical framework either. But this is what we proposed. And that was also the way I made the case for the provider outcomes, because we were really looking at the mediator was changes in provider attitudes, norms, and perceived behavioral control. So we start with organizational change capacity, a survey tool that Solberg has validated. I don't think it's the greatest thing, and other people are working on new ones. Organizational structure factors, which are FTEs, level of professionals, other things like size of practice. Then we implement, and our hypothesis is that the pay for performance will actually increase organizational priority around this, and we have a tool also to measure that, and that the other pieces, provider feedback, will change provider attitudes and norms, which will lead to increasing tension and changes in provider behavior. It's very hard when you're having the sample size issues that you have with these kinds of studies to say that we will definitively be able to measure mediation and moderation, but we were hoping to try. So this is I don't have to spend a lot, I just threw this up here, but I'm running out of time. So just to show you that common best practices actually is very high level in a sense. It's what I do with my cessation center. This is best practices, frankly, in New York, and I didn't see the point in dialing it back. This is what we do. It's staff training the guideline. Everybody gets a chart reminder system, a referral system to the quit line, and we have these toolkits. Arm 2 includes the chart audit and feedback, and then Arm 3 has pay for performance. And we're modeling our pay for performance after the Department of Health's pay for performance project they're right now doing with their PCIP project. They're paying doctors $20 to do tobacco use treatment. So any documentation of tobacco use treatment, they get $20. They cap out at 5,000. They do give them $20 because they're working in actually individual practice. These are small. You probably know this better than me. These are small practices, so they are giving the individual. This is a very important question, by the way, Joe, because my dilemma with
Believe me, I
this
know.
is that is when I was describing it. The problem is these are all community health centers. These doctors are all on salary. So who's getting the $20? And how does that affect provider behavior? Which is why we said that it would actually affect the organization. It was an organizational level impact, and it would change priority at the organizational level, which would then trickle down, hopefully, and affect the culture and the climate. But it's very tricky when you don't have direct payment capacity to the provider, because you're not really incentivizing the provider with this. As I think they are with the PCIP project, goes directly to the doctors. Because I kept getting tripped up on that. You know, that's the problem with the provider outcome being the outcome. It really is your implementation. The measuring the provider adherence is measuring fidelity. So anyway, yeah, these are great questions. Thank you. So the primary outcome was provider adherence, and then the secondary, we added this patient use of services and 3-month cessation. We're looking at fidelity of other things like whether the systems were put in place. We're doing site visits with checklists, standardized checklists to look at implementation. The process outcomes, or in other words, the hypothesized mediators, or the theory plan behavior variables and organizational priority scores, and the baseline organizational change capacity. Again, I told you we're using Solberg's measure. And the way we're, yeah, so that's that study. Again, we're just literally waiting to hear from our program officer. So this is really very much, you know, in the starting stages. And in fact, one of the cool things, by the way, if you don't know about this, is that the journal Implementation Science will publish clinical protocols. So if your grant gets funded, they don't even do a peer review because they assume it's been peer reviewed. And you can actually write a protocol paper and submit it, and the editor, if he likes it, will, you know. So if we hear a positive from this, I'm actually going to turn this into a protocol paper for them. And those protocol papers are great to read. You know, they're just, nobody ever publishes that. It's almost like reading the grant. You know, you get to get an inside scoop, people's measures, their outcomes, or, you know, it's a really great resource. Anyways, it's kind of getting, oh, it's really late. Well, let me just tell you quickly about this, because this is kind of fun, this study. I just finished a study where we partnered with Primary Care Development Corporation, Open Door Family Medical Centers in Columbia. I wrote this grant when I was at Columbia, so the data management group was there. This was a great opportunity that I was given by Primary Care Development Corporation. They were looking for a researcher, and they wanted to write this, respond to this RFA that came out of AHRQ 4 years ago. And Open Door are 4 community health centers up in Westchester that serve 80% of their patients are immigrant Hispanic patients from Central America, pretty much. And they have are working with ECW. They have an electronic record. So they wanted to look at the use of their electronic record, and hypertension was something they chose. This is the ideal kind of PBRN project, where the idea literally came from the practice. They came to us saying, we want to respond to this grant, and we want to focus on hypertension. What can you do for us? You know? And so we developed this proposal. And this grant has a lot of problems with it, because there were 4 sites. And I was tasked with the job of figuring out what kind of design to use to actually study the impact of this technology-driven intervention. So I scrambled around and found a lot of papers in implementation research that talked about alternative designs, and we came up with the idea of doing a time series analysis. There's still some, so I found a biostatistician to write the section, and we got through the study section. But on the back end, when the data was available, I couldn't get a single biostatistician to do the analysis that was originally in the grant proposal. I mean, it was unbelievable. So I'll show you what we did, but I'm hoping Yixin Fang is going to do this for us.
Why did they not do it, Donna? Why did they not?
I really, you know what my problem is, you know, you're at such a disadvantage when you don't really understand this field. So.
But they were saying methodologically?
Well, you know, then they were wrong. A couple of them are saying you don't have enough data points. That is just not true. We thought about that. We have 36 months of data, 36 data points, and they just pushed back. And I don't know why. And even when we went to Ennis, I actually told Columbia, I'm taking your contract and I'm taking it to someone else because I really want to do this. And I took it to Ennis, who is the data manager for actually the Pearl Network, great group, and they said the same thing to me. So I started thinking, well, maybe this is me. You know? I mean, it was just crazy because I know I'm right. I mean, because I looked at this research. I mean, I looked at how you do time series analyses, and there's no reason to think that we went out of our way to get the right amount of data. But again, this is, yeah, I shouldn't be like whining about my biostatisticians.
John,
Yeah,
I'm sorry to interrupt
yeah.
you, just curious, did you sort of randomize, I don't know, practices or patients, or did you do the intervention to
No.
all of the groups with a before and after design?
It was a before and after design, and we had to because they are one clinic essentially. They're one, they run as one community health center, and they run like a well-oiled machine. And I asked them, can we do a staggered time series? Because that's the better way to do a time series. I mean, time series. So that's the red alert for this was new, and what's funny about the red alert, that blood pressure was abnormal, is that when we looked at satisfaction, the red BP on the left, that was to them the most valuable thing we did. And it was the simplest thing, but it was by far hands down. It came out in the qualitative interviews also. Oh, we just love that red alert. there were problems with the order sets for a whole bunch of reasons. I don't have time to get into that. But we found out the qualitative interviews allowed us to really get at some of the other problems with some of these other systems. But what they did like qualitatively, we found out, was that they had choices. That they could use the template or not, they could use the order set or not. Least satisfied with provider feedback, which I find interesting. I don't think providers like provider feedback, so it's hard to ask about satisfaction with that. I still believe it does impact behavior, whether they like it or not. This is just to show that we looked at processes of care with our data. By the way, we were getting data, monthly data, every single patient that was seen. We had created a whole data file with variables that the site had to collect through the back end of their EMR, and they would send this data to our data coordinating center. And so that's baseline and follow-up, kind of aggregated data. So percentage of patients who had an EKG pre-implementation versus post. A BMED is chemistries and the lipids. So those went up actually pretty remarkably. BMIs went up. They weren't even asking about tobacco, so of course that went up quite a bit. I'm not going to show you all this data because that's not really what's sort of interesting. This was my time series, which never got analyzed. But what I thought was really interesting about this is that if you look at the left, that's only new patients. And the problem is the EMR started at time 0 there. And those patients weren't really new patients. So the blood pressure control was higher then. But then you start to see it go down a little bit because you do have a mix of new patients who come in with their blood pressure not as well controlled. What was important of that was to show that the new patients weren't coming in over time and having better blood pressure, and that's what explained the increase. That it was pretty steady, interestingly, over time. But we saw that there was this drop, and because of a whole lot of issues around the way the data is collected, again, the top number is high because that's not new patients. That's essentially their baseline, 52% control rate. They kind of get back up to baseline, in May or so, and then we intervene in November, and then you see this nice steady uptick in percentage of patients with controlled blood pressure. And this is the regression model that my new biostats team put together. It's a complicated, very nice, actually, general equation model that takes into account every single visit, and which the top number is sort of the most important, that basically patients were 1.5 times more likely to have BP controlled post-intervention. And just to end, I'm not going to show these, I just want to end that the qualitative interviews basically led us to this logic model, which was that the facilitators have changed based on our qualitative interviews with leadership and organizational culture that's really supported change. The rigorous project implementation process the providers really noted. The fact that we framed it as a quality improvement project, provider engagement from the beginning. They were engaged in the process of developing the tool. The perceived usefulness, and these are sort of the main domains that we came out of the qualitative interviews. Perceived usefulness of the intervention, there. So facilitators of change, the perceived usefulness of the components all led to changes in hypertension care. And again, these are from their mouths. They described being more aggressive, that they actually were more systematic about their care, and they paid more attention to it. And ultimately, we saw improved outcomes. So I'm not going to go through that. I just wanted to show that because that ended up being really an implementation study, and we approached it by using the mixed methods, which seems to be really necessary in this kind of work. I just wanted to end with the last couple of minutes just with some resources. There are 2 dissemination implementation PAs out of NIH. One is an overarching one, NIH, with a lot of institutes under it, and then NHLBI has their own. There's the Training Institute that I talked about. If I hear that they're doing it again this summer, I will certainly send out notices. It would be great if some folks from here could go again. I thought it was really great networking opportunity as well. There's actually something that just came out from OBSSR, Best Practices for Mixed Methods Research in Health Sciences, that might be worth looking at. And then the journal I referred to before, Implementation Science Journal. You should take a look at those protocol papers. Really interesting. I also can send everybody this. I got from Cynthia Vincent, a program officer at Cancer Institute. She went to the trouble of taking all the pink sheets from 4 years of reviews and summarizing what the key issues were. and this is my cheat sheet. It's not, these aren't all the issues, but I can send all of you this thing. It's really nice to look at. Because basically and when we wrote our grant, that's the dental grant that I just showed you, we literally checked off, every single thing as we had it in our grant. I mean, we followed that almost like an outline for the grant. So that was really nice that she did that, and so it would be helpful to look at. And the reason she did that is because a lot of people are submitting grants that just really aren't implementation grants. And they're not really answering the RFA or the PA, and they're not responsive. And so this was her attempt to try and help investigators understand this is what we're looking for. There's a meeting in March. It's free to sign up, I think. Yeah. So I'll skip that. And it's a really nice meeting. It's growing every year. And I've been there every year for the past 4 years, and I think if you're interested in this field, it's certainly worth going. And again, just to end, it's still a developing field. The theory's debated, the methods are underdeveloped. Why do we really want to be involved in this? Rapid change in publication outlets, funding is limited, although if you want to go to HRQ, there's more money. But I'll end with a slide from Brian Weiner, which I really like, that implementation matters. These are results from 5 meta-analyses that show that basically when they were implemented well, they had bigger effect sizes. So I'll just end with that. I'm sorry.